Hi, I'm Dr. Randy Martin. We're here at Mount Sinai. I'm a clinical professor of cardiovascular surgery. I'm thrilled to be joined by Dr. Ani Anyanwu. Ani is the vice chair and a professor of cardiovascular surgery here. Also is an incredible surgeon in all aspects, but runs the mechanical support and heart transplantation program. So, Ani, I appreciate you visiting with me and us, but really I wanted to ask you about a recent editorial that you and David did about a paper that was by Vinay Badwar looking at 53,000 people from the SCS data bank who had primary mitral regurgitation valve repair and comment about its safety. But you all had a really interesting editorial. Tell me a little bit about that.
Thanks, Randy, for the introduction. Vinay's paper was interesting because the whole aim of his paper was in the advent of transcatheter therapies and trials comparing catheter therapies with surgery. A lot of the trials some of the trials base entry point on surgical risk.
Right.
So Badwar and colleagues were trying to say, well, how many patients are there that will fulfill, for example, a high-risk cohort to test therapies? So they looked at the STS database and they actually what they found was surprising.
Oh, yeah.
In that, first of all, the mortality rate for mitral valve repair for all comers was very low. I think it was something like 1.1% for all comers in the United States.
I mean, it's 53,000 patients who had 2,400 different surgeons.
Yes.
So what makes that interesting is that the number of operations that were done per surgeon varied a lot.
It varied a lot. And there were some very low volume surgeons who did about one mitral operation every year because it was a 6-year study. And there were some who did over 100 a year.
Right.
And even if you looked at the low-volume surgeons, they had a very low mortality. So Dr. Badwar and colleagues then said, well, let's see how many patients are high risk. High risk would be operative mortality of, say, about 4%, 5%. Right. And it was something like less than 2% of patients. So it led us to write this editorial because it struck us that mitral valve repair is a very safe operation.
Okay.
No matter who does it, the operation itself is actually very safe. What that means is that the pursuit for alternatives should not be based on looking for something safer. It should be based on other factors. That was the essence of our editorial.
They were really talking about the risk of death, obviously, yes, at 30 days, and the risk of stroke and things like that. And you're saying that they found that it was pretty safe and a pretty low risk of morbidity, stroke, et cetera.
Yes, yes.
But they did also, then they find that the more you did, the better it was as far as a better outcome. Isn't that correct?
It was, but the effect was relatively marginal. So the very high volume centers had a mortality rate of just below 1%. And the lower volume centers had just above 1%, but it wasn't a striking difference like you see for most other procedures.
I don't mean to get you off track, but one of the things that struck me is that they did look at, I guess what they said, the intent to repair, but then having to go to mitral valve replacement.
Yes.
And when that occurred, because it was complex anatomy, that the risk of mortality and adverse events went up.
Yes, so for patients who the intent was to repair but ended up with a replacement, the mortality went up, which goes with what we know as surgeons, because the main reason to move from a repair to replacement is a complication that has happened. For example, it could be things like the heart rupturing during surgery, then that's a big problem to have. Or it could be that we fixed the valve and the valve is still leaking, and then by then you've been on the heart-lung machine for an hour or two, and that increases your risks. But of course, a flaw of the paper, it doesn't include patients in whom the intention was a valve replacement from the get-go.
Right. Okay.
So we don't know how many patients those are and how that would impact our, in general interpretation.
You made some excellent points in there, but you really looked at this whole concept that quality equals your risk of dying at 30 days, or mortality at 30 days is not quality.
No, it's not, because most patients are very much alive when they come to surgery for mitral valve repair.
Right.
Many of them are asymptomatic or have minimal symptoms. If the younger patients are still going to work, still, doing their day-to-day activities with their family. So if they're still alive 30 days later, you've actually achieved nothing because they were alive before. It's very different from other certain life-saving operations we do as heart surgeons. So, for example, if patients come in with a myocardial infarction,
Right.
that's a fatal condition if it's not treated. And then for myocardial infarction, you can use 30-day survival as a good outcome because the patient was dying when they came for the procedure, but not for mitral valve repair. And I think with mitral valve, a lot of parallel is drawn with the transcatheter aortic valve replacement.
Correct.
But aortic stenosis is a different disease. That is a fatal disease. If you have patients with critical aortic stenosis, if you look at both observational data and data from clinical trials, depending on how critical it is, some of them face up to 10-20% mortality within a year.
Right.
So for those kinds of surgeries, you can use mortality as an outcome, but not 30 days. You probably need to go to at least 90, 180, or 365 days.
We're looking at your editorial. Do you have some other information that we can share with the viewers on this presentation?
Once we accepted that mortality is not the outcome of interest, and the question then arises, what is the outcome of interest? What should be our benchmark when we're doing a mitral valve repair? And we then asked ourselves, well, what are the objectives of a mitral valve operation? Why is the patient there? So the patient's there because they have a leak in mitral valve or a stenotic narrow mitral valve, and that we want to relieve that leakage or relieve the narrowing. That's the first thing we want to do. And we want to do it in a durable fashion. So we want whatever solution we have to last the patient a long time. Okay. Hopefully their lifetime, but sometimes we can't get there, but at least several years. And we want to do this without causing harm to the patient.
Correct.
So we want the patient to survive, and we don't want the patient to have a stroke or any life-limiting complication. And we want to do it without any harm to the heart. So we want the heart to keep working as well as it was working beforehand. And we also want to look at the heart and provide the patient with a heart that is likely to allow them to gain the long-term benefits of the surgery. So we don't want to leave the heart with any conditions that might impact the long-term survival. And the commonest things would be a leaking tricuspid valve and abnormal heart rhythms, what we call atrial fibrillation. That's a problem if you get that in the long term. So we do procedures to prevent these from happening. And those are the key goals of what we're trying to do. And I think if we focus on those goals, then we will maximize the benefit.
In your editorial, you developed what you think, how we should look at mitral valve surgery. We're not minimizing the 30-day survival. That's important, but you're really looking at those things like procedural success, durability, long-term outcomes. Do you have a slide that shows that?
So we try to look at the outcome of a mitral valve operation in three different time points. So we talked of the procedure itself. So how do we say we've done a successful procedure? So
you're talking about over a 30-day. You do have a 30-day period.
Yeah, 30-day period. Okay. So you can say, well, the procedure has been successful. So obviously the patient has to be alive at the end of 30 days and hasn't had a stroke, not on dialysis, nothing major. But then the focus is on the valve. Okay. So we want a valve that doesn't leak at 30 days. So by not leaking, we mean there's nothing worse than a trivial or mild leak. Okay. So because there could always be a little leak, but that's fine. But you don't want a severe leak and you don't want a moderate leak.
Yeah, you all have been really pioneers in trying to make sure that when the patient leaves the operating room after mitral valve repair, that they're leaving with zero would be good, but maybe something trivial at most. Correct. Not moderate.
Correct. And to achieve that means that you have to accept that sometimes you have to go back and open the heart again to fix a leak. So, as you know, during the surgery, we have an echocardiogram done, what we call esophageal echocardiogram through the mouth. And then after we've done the repair, we examine the valve. If there's a leak still present, then we go back and open the heart again and try to fix it. And we do that in about 2 to 3% of patients.
But it's with this goal.
With this goal of...
That you know that procedural success, is based upon not having a moderate or worse leak.
Yes.
Then or in 30 days.
Yeah, and the basis of that goal is that we do know that patients who have what we call residual mitral regurgitation, which means at 30 days the valve still leaks, they have a worse long-term outcome. So if you want to maximize the long-term, you have to have a good short-term. And a good short-term means a valve that's not leaking at 30 days.
Okay. Then you talk about procedural effectiveness. Now, you've gone from 30 days to 1 year. What's that mean?
Yeah, so we're then saying that you also can't tell that the procedure is effective at 1 month. So even though I'm saying, well, the valve is not leaking at 1 month, that's not the same as saying we've had an effective procedure.
Okay.
Because 2 months later, the valve could fall apart, or the heart could, the ventricular, the function of the ventricle could fall apart. So the real assessment for mitral valve in terms of is it effective, not is it safe, is it effective, should be at 1 year. And at 1 year, you want to take a look at the valve with an echocardiogram and look at the heart with an echocardiogram. You want a heart that's functioning well. You want a mitral valve that's not leaking. You want a tricuspid valve that's not leaking. You want a patient that's alive that doesn't have symptoms or has only mild symptoms, and hopefully doesn't have atrial fibrillation.
But you also put in there that you want that they haven't had re-intervention. That would mean needing to go back for a surgical or other procedure on the valve?
Yes. So if a patient within the first year has had to have another procedure related to valve heart disease, or indeed related to the heart, then chances are that they didn't have an effective procedure. So even if it's an intervention on the coronary artery or on another valve like the aortic valve, chances are that happened because we did not address it at the first operation. So we did not do an effective operation. That's correct.
You know, I've sent you and David and the team up here a lot of patients who were asymptomatic but had significant mitral regurgitation, and I could prove they were asymptomatic. So the real argument is durability, especially as you get into younger and younger patients. So how do you judge the durability, which is the third leg in your stool here for you?
So I think the durability is at various points in the longer term. We would like to know if the valve is holding up, whether there's been any leakage and whether there's been any stenosis. Stenosis is narrowing of the valve. So basically, and you can't tell that till at least 5 to 10 years later. So I would say that to say a repair is durable, then you need to know that at least at 5 years, or probably later than that, that the valve still opens very well, functions normally. There's no narrowing of the valve, and the valve is not leaking. Then you would say you have a durable repair.
It's interesting that you always are coming back to at 30 days, 1 year, and 5 years to having no more than moderate MR to have effectiveness. Is that correct? I mean, that really is your benchmark there. I mean, one of the benchmarks.
Yeah, and that's born out of data from various clinical settings that show that patients who have moderate mitral regurgitation don't have as good a long-term prognosis as those who have mild. And patients who have severe mitral regurgitation don't have as good a long-term prognosis as those who have moderate. So we know that any degree of mitral regurgitation is not good for you. So we strive to get a patient at 30 days where the valve doesn't leak, so that the surgery has worked. We strive for an effective operation. So at a year, the valve's still not leaking and the heart's working well, and you have a patient who is out of hospital without symptoms. And we aim for durable repair, which means we want that state at 1 year to persist into the long term. And it's not easy to achieve, because we did write an early editorial a few years ago on a paper from Dr. Tyrone David, where he looked at 20-year outcomes. One surgeon. Over 20 years. Over 20 years. And he found out about a third of patients by that 20-year mark had, in quote, failed in these effectiveness criteria. So operations are not as good as we think they are. So we still have work to do to achieve that holy grail of an excellent. And you all learn. I mean, you know, you're doing a high volume. I mean, you and the team, you're doing high volume. You learn, you progress to improve over time. Isn't that correct? So yes.
If you look back, I mean, if you all look back, although I've got patients that I sent up to you all 15, 17 years out now, and their valve looks really good. But you learn how to improve your technique.
Yes, we do, because although their valves look good, there are also some patients that you've had and you've told us and said, look, the valve is okay, patient is okay, but the gradient is creeping up.
Right.
Or the posterior leaflet is very thick. So there are things that we still learn that we aim to perfect to see how we can push the bar from, say, a 10-year effectiveness to 15, and for the younger patients, 20, 30, or lifetime effectiveness of surgery.
So you made reference to the editorial you wrote about, I think you've got it in this presentation, about the long-term goal. So, I mean, the Badwar paper is really good because it shows that mitral valve repair in all hands is pretty safe. And you made the valid point that any transcatheter therapy should be, while people are pushing those, or that they have to be of equal safety and effectiveness. But this is really talking about, now you're really talking about what you need for this durability, long-term long-term care.
Yes. So basically, if one is, say, in their 40s or 30s, 40s, 50s with mitral valve regurgitation, and you're going to your doctor, you want treatment, I think these 4 things are the critical things for you, because in terms of fixing the mitral valve safely, as we've said, almost any surgeon in the world can do a safe operation. In terms of an effective operation, that gets a bit trickier. Then you need probably a mitral valve, someone at least with an interest in mitral valve surgery who can fix a valve and is likely to fix it well. But then you have to go beyond that and say, well, where am I going to be 10 years from now, 15 years from now, 20 years from now? And the things that will get you through, I think, are these 4 points that we made. And this was based on our observations from Tyrone Davis' 20-year outcome, because we then looked at his data and asked the question, what is it that makes patients not do well, say, 10 to 20 years after surgery? And it's these 4 things. Either they're getting the mitral regurgitation has come back, they're in atrial fibrillation, they have tricuspid regurgitation, or they've had some kind of thromboembolic event like a stroke. Those are the things that limit the long-term success for a young patient who has mitral regurgitation.
So this is what you would say your roadmap. I'm looking at minimize recurrent MR. So you want a surgeon. Again, the more complex it is, you would ideally want to go to a center that deals with complex repair.
Ideally, you'd want to go to a center or a surgeon who deals with complex repair. So the surgeon might not necessarily be in a reference center, but you just need a surgeon who does complex repair.
And then you'll do this what I was referring to. You've figured out the techniques that have proven durability for the valve to make the valve function as close to normal, and the heart.
Yes, so there's some techniques. For example, the Carpentier techniques are time-tested, and we know they work.
Okay.
There's some newer techniques, and I think surgeons have to be more cautious in adopting newer techniques unless there's a biological explanation that will support their existence and equivalence to established techniques. Otherwise, a lot of things being tried may or may not be successful in the long term. And I think for a younger patient, you really want time-tested techniques. And I think the other point is what we talked about earlier. You should have 0 tolerance for residual mitral.
That's what you're saying, yeah.
So don't leave the operating room with any regurgitation or anything more than a trivial regurgitation.
Then you're talking about thromboembolic blood clots basically embolizing, and you're really talking about coming from the left atrium.
Yes, coming from the left atrium.
Valve repair.
Of the valve repair or the atrial appendage. So there's still controversy about what we do with the atrial appendage. The atrial appendage is a blind sac in the left atrium, as you know, where that forms blood clots. So if a patient has had atrial arrhythmias in the past, then we should close that appendage and remove that source of thromboembolism. And a lot of surgeons increasingly are closing that appendage even in patients who do not have atrial fibrillation, but we're still waiting for data to confirm that strategy. And at least for the first 3 months after valve surgery, patients should be on some kind of anticoagulant or antiplatelet therapy. And there's a debate as to whether we should push that beyond 3 months as well.
Okay. But there you're trying to minimize that risk. And then atrial fibrillation is not a benign arrhythmia to patients. I mean, it compromises their function and puts them at risk. So What are you doing for that in that regard?
So in that regard, any patient who has mitral regurgitation having surgery and has atrial fibrillation should get an ablation procedure, what we call a MACE procedure. There has to be a strong reason not to do that. So there are some occasions, for example, if we have an 85-year-old patient who has been in atrial fibrillation for 10 years, fine, you don't, and you think it's going to add a lot of risk to the surgery, we don't need to do a MACE. But for most young patients with atrial fibrillation, so the first is if you have atrial fibrillation, we do a MACE ablation. And the second is for patients who have a history that suggests that they may have atrial fibrillation, anything in the history of findings. So, for example, a patient with a very enlarged left atrium, a patient who has a history of palpitations.
Right.
Those patients we think hard. I saw you yesterday talking to Mark Miller, who is our electrophysiologist in our clinic. So we have our valve clinic every Wednesday, and we have an electrophysiologist. Any patient we have doubts, we have Mark see the patient, and he looks at the patient, and if he has a moderate or higher index of suspicion that there might be atrial arrhythmia, he puts an event monitor on them for 2 or 3 weeks.
To document that.
To document that. And if we find paroxysmal atrial fibrillation, we treat that as well.
Okay. Then this whole question, which is a big debated question now and more, is that if the tricuspid valve is leaking a fair amount, you need to do something about it.
Yeah, I mean, we do know that the tricuspid regurgitation is one of the factors that limit the long-term benefit of mitral valve surgery. We saw that in Tyrone Davis' series. So a lot of the patients who die late after mitral surgery also have tricuspid regurgitation. Whether one caused the other is out to debate, but we do know from epidemiological data that people with severe tricuspid regurgitation don't live as long as people who don't have severe.
Right.
So it's a bad thing. I wouldn't want it. You wouldn't want it.
No.
So the question is, can we prevent it? And we probably can. Surgeons debate it, but I think the guidelines are now coming to the consensus that if you have moderate tricuspid regurgitation and you're having mitral valve surgery, that should be addressed. We shouldn't leave it alone. And we are also of the view that if you have the substrate for tricuspid regurgitation, which is a dilated annulus, we should also fix that so the annulus doesn't dilate further to cause tricuspid regurgitation. And I think if we can find a way to minimize late tricuspid regurgitation, late mitral regurgitation, and late atrial fibrillation, the results of this operation.
I mean, it's a great thing that patients should know. And, basically, I mean, and what a lot of people don't recognize, I think a lot of cardiologists know is that atrial fibrillation begets tricuspid regurgitation.
And mitral
regurgitation. Yeah. And so it's not an innocuous thing. And so by walking through this, you also had, I had a chance to look at these early, you had an interesting quote from Dr. Robert Dion, who's a colleague and a good friend from France and Belgium and other places.
Yes, I did, because it's a quote that I like. He, just before he retired a few years ago, we were happy to have him as our honored speaker at the Mitral Congress. And he gave a very nice talk. And this was my take home from his talk. And he said what he defines as a complete operation. And I put this up because there's a lot of focus now on how surgery is done. Is it done by a robot or a human being through a stenotomy, through a thoracotomy in New York, in Leiden or Toronto, wherever you go?
Right.
But that's not the point. He says he wants to remind us why a patient comes to us for an operation. They're not coming because they want the operation done. They might think that's what they want, but they're not coming to us to have the operation done through a particular incision, the size of the incision, with a particular technique, to have a quick operation, to have an operation without bypass, to have it done through the groin. We have to go back to the basics and ask, why is the patient here? And the patient is here because they want to be cured of their disease in a safe, complete, and durable fashion. Everything else is secondary, and our focus, we must not lose sight of our goal. And our goal is to give patients a safe cure, a complete cure, and a durable cure. It's not to do it through the groin or do it through the chest. Small incision, long incision, short bypass, long bypass. It's not for our reputation. And so, provided we keep that goal in mind, then we ask ourselves, what's the ideal approach for the patient in front of us to achieve that goal? It might be that it's with a catheter, a clip, for example. It might be that it's a transcatheter valve replacement. It might be that it's a stenotomy and a valve repair. It might be that it's a robot and a valve repair or something else. But I think we should not lose focus on that.
So yeah, you're doing what I like here, and obviously Professor Dion did this, is that you're really looking at what's best for the patient for this durability and safe outcome. And even at a place that's really world-renowned for mitral valve repair, you look at transcatheter therapies, and you have patients that you do mitral valve replacements in, because that's going to be best for the patient. So yes, you're telling the patient and referral physicians what they need to think about.
Yes, a safe care, complete care, and a durable care. If we focus on those three things, then we'll do right for the patient.
Having had a chance to, watch you all develop over the years and everything is why, because you do go by these tenets, that's why I've sent a lot of patients to you. So this is great information. As I told you and David, that the editorials, both those editorials were excellent because they look at this principle that you're putting out. So thanks for sharing it with us and sharing it with the audience. And we're glad that you could join us. I hope that you've learned a lot too.